Under Health Commune in Feb, we were celebrating World Cancer Day. We were creating campaign for early detection and early treatment for cancer. And in the month of July, when I'm discussing with Dr. Boman, we understand that medical advancement happen at such a rapid phase that we do not need to worry if the patient is been diagnosed at a little advanced stage of the cancer. No, there is still hope, there is still treatment available. And that's what we have discussed with Dr. Boman Dhabhar, who's a famous medical oncologist practicing at Fortis Hospital, Mumbai. Listen to our podcast and get to know so much about lung cancer and its treatment. Thank you.
The way we used to see earlier, things have changed. And earlier it used to be all widespread metastatic disease. We now still say, at least now I would say 10% of our patients would be even curable. Means they come in stage 1 to 3. Stage up to stage 3A, we say it's curable. So called at least. With a curative attempt, you can try. 3B onwards, we say it's a borderline curable, and 4 onwards is not a curable disease. With whatever advances that we have seen. If you have to see the advances, what has gone through last 30 years, which I have seen, and if you want me to tell you briefly how it has gone.
Yes.
When I was a registrar in Tata Memorial Hospital, maybe it was about 30 years back, the only drug we had at that time was, I don't know whether mitomycin, vinblastine and cisplatin. And that was a new protocol which had come at that time that could help. So we were excited using it. But we would see most of our patients could not tolerate that. And then as a policy, what we used to do, above 60 years, send them back home. Metastatic CLR. Of course, localized would always go for a surgery. But if it was a metastatic disease, we had nothing, absolutely. And we used to treat everybody same, except small cell and non-small cell. Non-small cell, whatever it is there. We never used to ask pathologists also. Whether it's a squamous, whether it's adenocarcinoma, everything was, we had only these 3 drugs. A combination of 3 drugs, I would say, MVP. So things started at that time, and slowly over the period of years, we started learning that yes, squamous cell is different, adenocarcinoma is different, we have to treat them differently. Slowly, IHC, as IHC became stronger, we started identifying that squamous cell carcinoma is different, adenocarcinoma. Then we understood that the behavior of this disease is different. Then came chemotherapy drugs more specific for adenocarcinoma, like pemetrexed. Pemetrexed, and then slowly came gemcite. We started using gemcite and taxanes for squamous cell carcinoma. For adenocarcinoma, we started using pemetrexed. So at least at that time, we knew, okay, we treat chemotherapy-wise differently. Till that time, we never knew that there is something like molecular biology which is going to come. Slowly over a period of years, it came that there is something like mutational analysis we should see. And those who have adenocarcinoma, they have the highest evidence of some mutational events which have occurred, by which we can pick up on the tumor block. So then slowly we learned, the first thing was that whether there is EGFR positivity or not. If there is EGFR positive, we know some tablets like oral tyrosine kinase works. In fact, I remember we did not have those also at that time. One of the patient at that time, maybe around 15 years back or so, one patient who had come from outside India, she fell. She was in Goa and she fell, and then she was brought to the hospital, absolutely in a very bad shape. She was on a ventilator at that time. And at that time, we just heard that there is a TKI available, and Jeftinib, we may get, on this patient assistance program, PAP. So we wrote to them, and Jeftinib came, and that was one of my first patients where through a rice tube we had given Jeftinib.
Okay.
And patient would fly back to Goa, where she came from.
Must have been a phenomenal response.
Phenomenal response. That was the time when we understood that even tablets can treat these patients. And this was totally at that time theoretical for us. He has Jeftinib tablet, and all our colleagues were so happy that, the patient went home. The intensivist, everybody. So that was the time then we realized slowly, then after Jeftinib came erlotinib, then came afatinib, and now we are one of the top of the drug called osimertinib, in the same EGFR mutational analysis mutation patients. And now we know that we have so many different type of drugs available for one thing. At one time we did not have anything, then we have only Jeftinib, and now we have about 4 drugs from which we have to select. Obviously, we don't have to, we select because of the financial constraints. Osimertinib we know is one of the best drugs in the oral TK. And mind you, these are all tablets. And we have seen phenomenal results. Few of my patients with brain mets have survived on this TKI for years and years together, even with brain mets. Of course, many of them received radiation to the brain and they are surviving for years and years together. So this is the evolution which has occurred. After EGFR came I, then came ROS, and now we have got an NCCN panel of at least 9 drugs, 9 mutational analysis that we would do to come to a conclusion that which TKI would be useful for which. And then, of course, now we have immunotherapy with us. With immunotherapy, we all know 20 to 25% of our patients will survive 5 years with a metastatic disease. And that has been shown in our ASCO also, one of the plenary sessions a few years back, that only on single agent, pembrolizumab, people have survived for 5 years, 20 or 25% of our patient metastatic disease. So this is all the evolution that we have seen from no drug, no treatment, to now we have to select out what treatment is good for our patients.
So one small question, like for CA lung patients, based on histopathology, you must be advising, okay, which molecular genetic test to do. So what is the response in terms of uptake, or what are the barriers for actually getting this test done apart from financial?
The barriers are usually turnaround time. Finance is, of course, one thing, as you rightly mentioned, but turnaround time is a barrier here. Because what we usually get in practice, the PDL1 test is done by an investigation called IHC, immunohistochemistry.
Yes.
So PDL1 report comes within 3-4 days. Then comes by NGS we have to send. When we send for all these things, that report takes about 12 to 14 days at the earliest. Like EGFR, AL, cross-variants and everything together takes at least 14 days. So it's like this. Once the patient knows that he has a metastatic disease, he doesn't want to wait. He wants to start the treatment. So it's a barrier in the sense that we have to go and requesting or telling or informing our patients rather, that see, starting a wrong treatment will not be good for you. So if this patient is EGFR positive or IL cross, any one of those mutations are present, and we give them chemotherapy, there are multiple trials that they have shown that chemotherapy is inferior to those drugs, oral tablets. So we are not giving the right treatment unless it's an emergency. It's an emergency, an oncology emergency where you have to start immediately, then it's a different story. Then we have to start, of course, chemo and we wait for the reports. But if there is no emergency, the patient is stable, the patient and the relatives still want some treatment to be started. Why are we waiting, doctor, for the reports? You know you have a cancer. Why are you waiting? You know, and you are telling us it's a 4th stage cancer.
So how commonly you utilize medical genetic consultation or genetic counseling services? Because as you mentioned, patients are very anxious. It's very difficult stage when diagnosis is done and treatment is not being started because of the barrier of the TAT. So maybe these services could address these issues. What is your opinion about it?
These services can, yes, definitely. But ultimately, it's a decision the doctor has to take when to start a treatment.
Yes.
This decision may, discussing with them, everything, they will always say that whatever doctor says, do that.
Yes. Yes.
So it's, and these are all patients who are very anxious, who have come for the first time, and you have just started developing a bond with them. So I think so, putting in a service like this, it's good for the patient and the relatives to explain to them that sometimes in our busy practice, we may not be able to explain that there are so many studies which they have shown that, these drugs, tablets are better than even chemotherapy. Everybody has a concept of chemotherapy, you have to start. So this concept, at least somebody can tell them in detail, sit in the room and explain to them. Yeah, that's a good suggestion.
Yes.
So whenever we talk about cancer, we say that if the patient is diagnosed at a very early stage and we start the treatment very early, then the survival chances are larger. But you are saying that even at the metastasis level, now we are able to save patients.
Oh, yes, absolutely. With these TKIs, what has happened, I'll tell you, some of our patients, it's become like diabetes, chronic disease. They just go on taking tablets and they live very well with a very good quality of life.
Beautiful.
The first generation TKIs, what we had, Geftinib or Lotinib, then came Afatinib, and the third generation, Osimertinib. The first generation, we have a little bit of more side effects. Side effects in the sense skin rash, loose stools. Whereas with the latest drugs, I have hardly seen any side effects by which we have to stop the treatment. We modify a little bit the dose, and patient can tolerate it. So it is like a chronic disease.
And I think cancer is still a big taboo, right? Like people are scared.
Absolutely. Unfortunately, you are right.
But I think with this information now, at least they will feel that, okay, even at the advanced stage, you can live longer. So you also said that
But we don't want to catch them at an advanced stage.
True.
Yeah. The priority is catch early.
Catch early.
But-
do some good prevention things.
But even like I think lung cancer, it's very asymptomatic at the initial stage, and by the time patient
Many times, yes. And many times it's like cough going on.
Correct.
People think it's infection, then comes in many doctors that coughs comes in the mind. Tuberculosis being so common in India, they think tuberculosis treatment goes on.
And they keep treating
Treating it, and then somebody gets an idea, no, we should go CT scan also, so long, then the thing starts.
Correct.
So, in your practice, like we have an entity called hereditary cancer syndromes, right? So, CA lung doesn't figure in any of those.
Yes.
But have you seen any clustering of CA lung in families or relatives in your experience of 30 years? Has it ever been like that?
No, not like that. But unfortunately, I'll tell you, I have seen, which is just, I think, a coincidence, husband-wife.
So, maybe
It was 2 or 3, yeah, maybe you're right. Husband was smoking and there was a passive smoking. Husband-wife, I've seen at least 2 or 3 like this are our patients, couples.
Yeah, there was like one paper that I came across where various cancers, in particularly CA lung, they were able to identify in 4% of the cases some inherited variants in known genes which are known to cause hereditary cancer syndromes, and CA lung was one of the presentations. So yes, we need to look into data and just understand there are a lot many dynamics, because CA lung is more of genetic predisposition on one side, but more of exposure.
Absolutely. It's more of environmental exposure.
yes.
It's more of an environmental exposure disease than genetics.
Yes.
Sir, you said that now even in women, lung cancer is pretty common. And what's the causative factor? Do they have any specific pattern or history that they are coming up?
No, nobody knows really what is the causative factor for that. But it is believed that how you metabolize your carcinogens is important.
Okay.
Now, everybody is inhaling carcinogens. But what is the genetic predisposition to metabolize these carcinogens? It is believed that females cannot metabolize these carcinogens so easily. So they can stay with these carcinogens a little bit longer.
Okay.
Males tend to destroy those carcinogens, metabolize those carcinogens a little bit earlier. So many females who are even taking that slight smoke may develop malignancy. That is one of the hypotheses of it.
Okay. But we do not have any strong study that helps us to understand it.
So much information in such a short time. It was like walking through those 30 years like of your experience, like how it started and now where we are.
It was 30 years back. Even a 60-year-old man. Now I have treated, I'll tell you, the latest is 90 years also on immunotherapy.
That's really wonderful.
It's such a smooth thing. Immunotherapy, exceptionally well tolerated.
And what was the youngest patient that you have treated in your practice?
And lung cancer. Lung cancer?
Yes.
We were around 28, 38 or so, 30 years old.
A 90-year-old.
90 years also I got. 75, 80 how many?
And what's the most common age where it is starting right now?
Usually say 55 to 70 is the commonest age where I see it.
Not the younger population.
No, usually is the most common that I see.
And do we see that, is it more towards the major cities? Because your patients are global patients, right? So are they coming more from the major cities or?
I think so. The diagnosis occurring is more in the major cities. Otherwise, people would say, oh, he died because of infection, cough, he died because of this. So it's catching the disease early on. So it's very important. And one more thing that everybody should know, that nowadays, because we have got so many tests, don't do FNAC and diagnose anything. You require always a biopsy. A true cut biopsy is the most important thing to diagnose a lung cancer. Because the thought process is in some small places. Now, most of the people just do FNAC or lung cancer, and then they say it's a very advanced disease, let it be. So it's an education to all our peers, everybody.
True.
That no, it's an advanced disease. Do a proper biopsy, come to a proper diagnosis, do what is called as immunohistochemistry, do mutation analysis, and then decide what is to be done. Don't take a very harsh decision of not giving the advantage of the science just on the basis of an FNAC and seeing the patient clinically.
And both the problems, like doctors, those who are from the remote areas or from the smaller town, first thing, they fail to diagnose at the initial level. Second, they fail to suggest. I feel that they are not even aware that such kind of things are available now.
The interventional radiologist also take an important part in this.
True.
No, because do a proper true cut biopsy from a lung requires some skill. And a person who is doing it regularly.
Correct.
Because they are all lung malignancies also. So it has to be a proper true cut biopsy. And unless it's a multiple core, you are again lost. Of course, nowadays the tests come like circulating tumor DNA, by which also you can make out liquid biopsies have come. But liquid biopsies are a very small number of patients who can afford all those things.
Yes. More of prognostication or disease monitoring maybe
Disease monitoring also, prognosis also, but now US FDA has approved
for diagnostics.
for diagnostic also.
And-
In lung cancer for mutations, they are approved.
Yeah. And so there are certain tests which claim to like as a screening tools for diagnosis for CLR. So what is your opinion on that?
Diagnosis, early diagnosis is the low-dose CT scan. That's the one of the famous trials.
Blood-based
Blood
testing.
based.
Yeah. So like liquid
They are
biopsy.
coming up in a big way, but I don't think so. Right now, it's a prime time to diagnose only on the blood.
Yes. So validation studies for
Validation studies are required, absolutely.
maybe clinical validation studies would be more authentic.
Absolutely. Clinical, radiological correlation with
Yes.
circulating tumor DNA.
Correct. Absolutely.
And do you suggest, like, of course, I do not know how much of the hereditary impact is there, but all the cancer patients who are treated with you are treating them, do you suggest their family member to go through any kind of a...
It depends on what disease you are looking at, what age you are looking at, what family history they have.
Okay,
These
not
two
that,
things.
like,
No, not each and every patient, no. Not each and every patient. Not each and every patient of breast cancer also, where we know it's about 10 to 15% can be hereditary, still we will not do.
Okay.
But in ovarian cancer, we do those tests because we have got therapeutic implications now. We do the test, BRCA, because there are therapeutic implications. In breast also now, therapeutic implications have come. So we do the test many times for therapeutic implications also, but in the process, of course, the hereditary tendency also comes out. So where there are therapeutic implications, we have to do it, there is no question. And when there is a strong family history, everything, of course we do.
So that is for like cascade screening of the relatives.
Relatives, that's right.
So we can put them on maybe surveillance.
Surveillance, absolutely.
Screening and surveillance. Yeah.
Yeah.
Like currently everybody is talking about like ChatGPT and technology is trying to replace the doctors and AI is going into this. What's your opinion about that?
It's good for a person to know all this information, but I don't think so. By this information, they should challenge a practicing doctor. It's good for them to know everything, but sometimes some patients come like few days back. A patient came to me and she tried to go through the whole history. She said, "No, sir, you have to just tell me, should I do DOTA scan or should I do a plain FDG PET?" He will ask me that, but sir, I have to know everything now. So all the information together, they think that they are quite superior and they feel that I've read everything. So I have to ask just one or two questions and I go. So that is not the right thing, I think, sir. So it's good to be informed, but we cannot challenge a doctor for this. That what you are thinking is on the basis of what I have read. So ultimately, the experience also which matters.
True.
Seeing daily same thing day in and day out, you can see the patient, you can say whether it's suitable for chemo or not nowadays. When the patient enters only, I can say many times in my room whether the patient is suitable or not. But they will say, no, you have to give chemo. And I tell them that please go to another doctor.